Thank you, Dr. Chandrakant. At the outset, I would like to thank Dr. Milen, Dr. Neeta, Dr. Rohini, Dr. Vidya, Dr. Rajiv, Dr. Chandrakant, Dr. Lalita, and Dr. Amrita, and all Solapur societies, for giving me this opportunity. I'm happy that interested obstetricians are around, so I'm very, very happy to talk before you. So I'm going to talk on management of GBM, tips and tricks. All of us are aware that diabetes in pregnancy can be pre-existing, type 1 or type 2, and gestational diabetes. So if comes before 20 weeks of pregnancy, it is a pre-existing diabetes, but it is diagnosed during pregnancy. So this is not a true gestational diabetes. And a true gestational diabetes mellitus, which comes after 20 weeks of pregnancy. So it is a metabolic disorder. It is defined as glucose intolerance of a variable degree with first onset during pregnancy, and there are the various methods which organization has given us. So let us look at this. Hyperglycemia in pregnancy is a challenge. There are 127 million live birth occurs per year, affects 1 in 6 pregnancy worldwide. The prevalence of GDM in India varies between 3.8 to 21%. 21 million per year are complicated by hyperglycemia. 3 to 4 million detected and treated, and we don't know how many gets the advice and stick to the advice postpartum. So GDM may play a crucial role in the increasing prevalence of diabetes and obesity. Professor Sasai has rightly said, GDM is the mother of non-communicable diseases, and David Barker, fetal origin of adult diseases. So today we realize it is very, very true. So if you look at the pathophysiology of GDM, maternal hepatic glucose production increases by 15 to 30% to meet the fetal demand in late pregnancy. At the same time, there is insulin resistance due to the placental secretion of anti-insulin hormones. So pancreatic beta cells, which are well functioning, they can compensate by increasing the insulin secretion. But if there is a dysfunction due to genetic, autoimmune disorder, chronic insulin resistance, it leads to gestational diabetes mellitus. So these are the risk factors. We all are aware about ethnicity, Western diet, maternal age more than 35, family history of diabetes, PCOS, excess of weight gain, previous delivery of macrosomic baby more than 4 kg, history of baby with congenital anomalies, obesity, and BMI more than 30. So that there are various risk factors which we have to take in account. So what are the maternal problems? It can cause spontaneous miscarriage. It can cause PIH, UTI, hydramnios. It can be preterm labor, more instrumental delivery, traumatic delivery, more cesarean section rate, PPH, more maternal mortality and morbidity. At the same time, there may be complications like hypoglycemia and diabetic ketoacidosis. Piperium, it can cause infection, lactation failure. And what are the long-term consequences? The patient retains the weight, GDM in subsequent pregnancy. She becomes a type 2 diabetes mellitus, and of course, it is associated with the cardiovascular diseases. So, fetal problems. There is a congenital malformation. As I said, the GDM occurs almost after 20 weeks of pregnancy. But if we are not diagnosed pre-existing diabetes mellitus, then there is a hyperglycemia state in a first trimester. And this hyperglycemia state in first trimester is responsible for the congenital malformation of the fetus, and most common are CVS and neural tube defect. Macrosomia usually is a gestational diabetes mellitus. What happens when the mother has a high sugar level? The insulin produced by the fetus also increases, and there is a deposition of the fat, and therefore the macrosomia occurs. There are more chances of stillbirth. Sudden stillbirth, you have IUFD, you must have heard, neonatal death, shoulder dystocia, RDS, cardiomyopathy, hypoglycemia, hyperbilirubinemia, polycythemia, hypocalcemia. And what is the long-term effect on the fetus? Once the baby is born, they are overweight or obese. Type 1 to type 2 diabetes can be seen early age, increased cardiometabolic risk, and it is also said they have more chances of cancer like breast, colorectal, and ovarian. So this is a pregnancy is a really, gives us the opportunity to screen the patient, whether she is diabetic or not diabetic, and according to we can start the treatment as early as possible. So what is the screening? In the past, there was no universal screening, but now we all of us agree there should be universal screening at the first booking, that is Government of India and DIPSI recommend, and at 24 to 28 weeks, and DIPSI also recommend at 30 to 34 weeks of pregnancy. So pregnant women, what usually we prefer in India is DIPSI, that you give 70 gram of oral glucose irrespective of her fasting status, and you do the sugar after 2 hours. If it is less than 140 milligram per cent, she is negative. Repeat testing at 24 to 28 weeks. If she is negative, then look after her as a normal low-risk patient. If she is positive, then manage as a GDM. Now look at on the other side. As soon as in the first visit she becomes positive, that is more than 140 milligram per cent, manage as GDM guidelines. So it is interpreted DIPSI says that if you find during pregnancy the sugar is 200 milligram per cent, remember she is a known case of diabetes. If it is between 140 to 199, she is a gestational diabetes. 120 milligram to 139 milligram per cent, she is a glucose intolerance, and normal is less than 120. Level of HbA1c is not that important, they found out. So we should not waste time or money on this HbA1c, but we have to believe in our DIPSI test. So management, obstetric management and glycemic management. So we know the primary management to control glucose is the nutrition therapy as well as the exercise. Within 2 weeks, it doesn't change the blood sugar level. It does not lower down. Then we have to put on the anti-diabetic drugs like insulin. Many of the people prefer as a first line of treatment, and then, if not possible, metformin. But I have seen my colleagues, obstetrician, they prefer metformin compared to insulin. So now, pregnant patient whose blood sugar is more than 140 milligram per cent, she is given a medical nutrition therapy with physical exercise. You repeat it after 2 weeks, and 2 weeks it is less than 120 milligram per cent, then you do what you say every month this test and see that she remains the low risk. But after 2 weeks, if her sugar is remain more than 120 milligram, then you will have to start either oral antidiabetic or insulin. Monitor her frequently when you start the treatment every third day, and you increase the dose accordingly till it becomes stable, and then you according to guidelines, you do her blood sugar level. So how medical nutrition therapy helps? The ultimate goal is adequate nutrition, adequate weight gain, prevention of ketosis, prevention of postprandial hypoglycemia. So we know that when normal mother we want to give a diet, it should be 30 kilocalorie per kg, and if it is a obese woman, we should restrict to 12 kilocalorie per kg, and diet should contain 50% of carbohydrate, 20% of protein, and fat to 20 to 30%. And it should be divided in 3 meals and sometimes in 3 sects also. So you give little food so the hyperglycemia does not go high. So you give divided food, meals with the snacks. And remember one thing, when you reduce the carbohydrate content in the obese patient, she is likely to develop ketosis, and therefore when she develops urine ketone or a blood ketone, it is better to not to restrict carbohydrate intake. So if the patient is more than 30 BMI, it is better she puts on only 5 to 9 kg of weight and not normal like 10 to 12 kg. So insulin initiated therapy. Once you start the medical nutrition therapy with exercise, 50% of the patient respond and 50% they don't respond. And then you have to put her on an insulin therapy, and the ratio is usually 2/3 should be given in the morning and 1/3 should be given in the evening. That is of short 1:2 ratio, that is short and intermediate. But when you give a long acting, the half-life is more than 24 hours. So it will interfere with the insulin level and patient can go frequently into hypoglycemia. So initially we start with the insulin 0.1 unit per kg body weight per day. Third day you do the test and increase the dose accordingly, and rarely patient requires 20 units of insulin per day. And it is very, very safe during pregnancy. So how to recognize hypoglycemia? So early symptoms are tremors of hand, sweating, palpitation, hunger, easy fatiguability, headache, mood changes, etc. In a severe form, there is confusion, abnormal behavior, visual disturbances, anxiety, and very uncommon is seizures and loss of unconsciousness. So what you should do when person complain of such complaint, you should immediately put a 3 teaspoons of glucose powder, if available, into glass full of water and let her drink completely. And if glucose is not available, at least put 6 teaspoons of sugar dissolved in water or a fruit juice or a sweet, and you give her. Let her rest for 15 minutes and let her take after 15 minutes. You give her to eat something. And if she has a repeated attack like this, you can give another dose of glucose. But remember, if the patient gets repeated attacks once in a day of hypoglycemia, she needs investigation and treatment. Now, metformin, it is an oral hypoglycemic drug. It is insulin sensitizer given with the meal. You can start with 500 milligram and you can increase up to 2500 milligram. There is no teratogenic effect and it is B category drug. So government of India recommend it is after 20 weeks of pregnancy, but most of us we know that these patients are PCOS. We have already started metformin and we are continuing with the treatment because it is a B category. Teratogenic effect is not reported and it is easy because patients are very, very comfortable with the oral drug. It is cheaper, it is acceptable, and there is very few side effects like hypoglycemia. Now, monitoring of this patient at least 4 times, that is fasting, and after 3 postprandial. And after achieving the target, you continue the same up to 20 weeks of pregnancy, 28 weeks up to 28 once in a month, 28 to 32 weeks once in 2 weeks, more than 32 weeks once in a week. And you should also monitor fundus and microalbuminuria. The target is to keep 90 milligram as fasting and 120 milligram % as PP. So fetal monitoring, we all are doing this routinely. What extra we can add? So first trimester, clinical examination, dating scar, anti-scan, your dual marker, uterine arteries prediction and preeclampsia, umbilical arteries, middle cerebral artery for the IUGR. Now second trimester, again clinical examination. We should not forget about the clinical examination because I have seen majority of them are doing, because everybody has in a nursing home the sonography. So everybody is the technologically based, even the weeks of gestation. Then your triple or quadruple marker if the dual marker is not done, because nowadays we don't advise both the markers. And of course amniotic fluid index and fetal 2D echo. I remember when I was resident, we had a patient with infertility conception and we did a congenital malformation. Those that dual marker, quadruple marker were not available and we were never doing 2D echo. of the fetus, because at 18 weeks she turned out to be no malformation. And you believe me, we delivered her by C-section. They were so happy, couple was so happy, they got a sweet. And after 2 days, we found out, we realized baby had a severe congenital malformation and we lost the baby. So nowadays, such situations are very, very rare because our technology has advanced and we all are taking and giving the patient advantage of technology. Of course, third trimester, fundal height, growth scan at 28, 32 and 36 weeks with color Dopplers. And of course, we have to also see amniotic fluid index and non-stress trace when indicated, and so patients especially on insulin. So what is a diabetic ketoacidosis? There is a positive serum urine ketone, then blood sugar level is more than 200 milligram per cent, low serum bicarbonate, elevated base deficient, and potassium level may be normal, but remember it may vary and you have to be taking care of that. So what is the management? The patient is dehydrated, so in the beginning you have to give 1 to 2 liters of isotonic saline in first hour, 3 to 500 ml per hour, saline, and then add 5% dextrose if your blood sugar is less than 150 milligram per cent. Insulin therapy should be started 0.4 unit per kg as a bolus, then continuous infusion 6 to 10 units per hour, double the infusion if the sugar is not getting under control, and then you reduce the dose accordingly and continue at least for 12 to 24 hours till the crisis goes away. Then electrolyte replacement, especially potassium, search for the infection like other factors which is responsible for the diabetic ketoacidosis, and they require high dependency unit where all the care is taken. Now, if you see what is the cause of fetal death, all of a sudden the fetal death occurs in diabetic ketoacidosis. I have seen not only diabetic ketoacidosis, but also in patient with the sugar, diabetic patient with high sugar. Because I remember that there was a twin pregnancy, patient was a gestational diabetes, and we were planned to do a section next day. Previous day the scan was done, fetal hearts were normal in both the twins. But when patient went for the admission, there were no fetal hearts found. And the twins pregnancy, infertility conception, it is difficult to explain. So what happens? The severe maternal dehydration with acidosis reduces utero-placental perfusion in an acidotic environment. And there is electrolyte disturbances which can cause maternal cardiac arrhythmia, at the same time fetal cardiac arrhythmia, which is responsible for the sudden death. So when to deliver? FIGO recommendation is at 38 to 39 weeks. Then if the baby's weight is less than 3.8 kg, poor control, poor compliance, previous stillbirth, vascular disease, if they are not present, then don't do anything. Allow her to go into spontaneous labor at 40 to 41 weeks. At 38 to 39 weeks now, if the baby is between 3.8 to 4 kg, that is large for gestational age, then you can induce this patient provided the Bishop score is good. If the Bishop score is not good, your induction of labor is going to fail. So first you have to improve the Bishop score and then do the induction of labor. And if it is more than 4 kg, then don't try anything. Just go for elective LSCs. So this is the FIGO's classification. The special precaution during labor is that you have to take that whenever you want to induce or whenever you want to do an elective section, omit the morning dose of insulin or metformin and do 2-hourly blood sugar level, and you have to maintain it from 90 to 120 milligram. If it goes below 70 milligram per cent, patient is in hypoglycemia. So these are the during labor what doses you can give. If it is 90 to 120, no need to give insulin. 120 to 140, 4 units, 100 ml per hour. 140 to 180, 6 units, 100 ml per hour. More than 180, 8 units per 100 ml per hour. So this is the Government of India guidelines says. So labor management is first stage. If patient is not only on the medical nutrition therapy and exercise, admission stays, partogram, and 2 hourly blood sugar, and maintain it to 80 to 120 milligram. In second stage of labor, if the patient is on insulin or metformin, similar, but you have to start IV fluid, institutional delivery, presence of expert obstetrician, and close electronic monitoring. During labor, you have to second stage, if the ARM, if the membrane is intact, I'll take 2 minutes. So if membranes are still intact, do ARM, and you expect shoulder dystocia, so the senior obstetrician should be present, and also the neonatologist and the trained person to resuscitate. And close monitoring second stage, watch for fetal distress, vaginal delivery, but in indicated patient, obstetric indication or large for baby, LSAS should be done. Active management of third stage labor, and they are going to have atonic pH and traumatic pH or both. You should look for that. It's not moving. I think they've stopped. Yeah, so immediate neonatal care, this is very important. You should put the baby to the breast within 1 hour. And the cutoff is 45 milligram per person for average gestational age, and 56 milligram person for small for gestational age in babies. If you find these are low, then baby is going to go into hypoglycemia, and you should start breastfeeding immediately, and if you find below cutoff, you should give glucose to the baby. And every 4 hourly you should feed the baby, but I have seen the newly born babies, they keep on sucking, and you have to monitor the blood sugar 4 hourly, and if the fourth time the sugars of baby are coming normal, no need to monitor. Evaluate neonatal for RDS, convulsion, and hyperbilirubinemia. Because RDS is known, even it is a term baby, so we have to look for that. So focus of area of postpartum care is diabetes screening with risk stratification, lactation support and education, continued lifestyle modification, contraception, and family planning. So we know as soon as the baby is delivered, the blood sugar comes to normal. But when patients are not on anti-hypoglycemic drug, they don't require these drugs. But if the patient is on insulin, then third day, every patient third day you do the sugar level, and insulin requirement will reduce to 40%. So you do on the third day, 6 weeks postpartum, annually, and before planning for the next pregnancy. So lactation support is very, very important, because we should encourage the patient for breast milk, breastfeeding. Lactation has advantages, affect on glucose and lipid metabolism in postpartum GDM women, and chances, it has been reported, the chances of developing type 2 diabetes comes very long time if she has breastfed the child. The American pediatrician, they refer 1 year, they suggest 1 year, recommend 1 year breastfeeding, and WHO 2 years breastfeeding. So how to control diabetes? Diet, exercise, education, that means awareness, medication, and regular monitoring. These are the postpartum contraception. You have a basket of it, but I am not going into detail because of the lack of time. But you should remember medical eligibility criteria for contraception user prefer are intrauterine contraception. But when patient with the vascular disease, try to avoid hormonal line of contraception. And long-term consequences, 10% are diagnosed diabetic at 6 weeks postpartum, 50 to 60 develops type 2 diabetes in 5 to 10 years, 30 to 40% develops GDM in next pregnancy, 25 to 30% of the offspring of diabetes patient develop type 2 diabetes and other serious problem in second decade of life, that early. And all GDM women require counseling and lifestyle changing. Preconception counseling, nowadays all the girls are getting educated, they come to us for preconception counseling. So her BMI is more, then make her to go BMI below 27 kg per meter, and the blood sugar should be maintained below 95 gram per cent. So you know the key points: universal testing at first visits, 24 to 28 and 30 to 34 weeks. Single step, 75 gram glucose, 2 hours, the blood sugar is done. And all the pregnant women, more than 140 milligrams should be tried with the nutrition, medical therapy and exercise. I'm not going into detail because these are the same point, but I want to talk something about it all start in utero. So diabetes-free generation. Focus on the fetus for the future. This has been said by Padma Shri Professor V. Sheshai, father of GDM in India. And I had an opportunity to deliver, oration on his name at Madras Medical College. And I was really honored over there by him. So what his theory is: primordial prevention of hyperglycemia. How can you make a generation free of diabetes? So he had done a study that at 6 weeks, conception, you do a blood sugar, and if the PP is more than 110 milligram per cent, put her on the medical nutrition therapy and certain exercises. At 8 weeks, you repeat the blood sugar. If it is more than 110 milligram per cent, start metformin. As we said, organogenesis majority has been taken place by 8 weeks, and metformin is a B drug. Start metformin. At 10 weeks, again repeat the blood sugar. Why we want to start metformin? Because at 11 weeks, the fetus starts producing insulin. So we want to keep that blood sugar below 110 milligram per cent. So fetus will not produce more insulin, and this will give us the future generation free diabetes. Thank you once again for giving me this opportunity.
Thank you, madam, for such a nice and elaborative talk. These practical tips always helps to manage the GDM. I think. Anyone want to any inputs?
I think everybody wants to rush for the workshop. Thank you.
I request Dr. Nita Ghate madam and Dr. Milind Shah to come on the dais to felicitate Dr. Madhuri Patel madam. I request Dr. Rohini Deshpande madam and Dr. Rajiv Dabde sir to join. I request Dr. Amruta to join.